Hi, everybody. Thanks for joining us today. I'm Nicole Clement, a program specialist here with the TASK program at the National Rural Health Resource Center. Before we get started with our topic, just a couple of reminders. First of all, if you are in a state flex program, I see some people that are not, but if you are, you should have received an email from Caleb or Matt or I or possibly Tracy about your state flex profile to please update them. Please take a minute to do that. We were requesting that information back from you by the 14th, so we'll send out some reminders about that. Also, please consider if you haven't had a profile in the past, all that is showing right now on the website for your state is contact information. So it'd be really great if you could provide some information about the initiatives of your state flex program. State flex profiles are some of the most used web pages on our website. I think you guys find them valuable to know who might be doing work that you're interested in and that sort of thing, as well as contact information. So take a peek at that email from us and get that information into us, please. The next couple of things, then February 3rd, we have a Rural HIT Coalition call that's going to be about rural health information exchange. You should have received some emails from Kiona about that with a calendar appointment you can add. February 22nd is the next TASK 90 webinar. That one is going to be about health equity. So those are the reminders that I had from TASK. With that, I'm going to turn this webinar over to John Gale of the University of Southern Maine Flex Monitoring Team to talk about EMS data to support rural EMS improvement.
Great, thanks Nicole. So I've had my slides up. I'm going to go through them relatively quickly. If you have questions, I'm okay with answering questions on the fly. Either interrupt me or use the chat box. I'll try to keep an eye on it. But what we've been doing here at USM with the Flex Monitoring Team is putting a fair amount of time thinking about what data is available to support rural EMS improvement. And we've done a number of projects where we've identified measures related to rural relevant performance EMS measures. We've looked at state data collection and given it a lot of thought. And as part of that work, we've had a couple of projects where we used expert panels. And we had folks from state EMS agencies, flex programs, EMS experts, folks like Gary Wingrove and Kevin McGinnis, and others. So we've spent a lot of time. So what I want to do is talk to you a little bit about some of the data sources that I don't know that are always getting used by flex coordinators. Let me see how this works. If I get, there we go. So a couple of things we're going to do is talk about sources of data, state EMS agency licensure information, personnel information, run data, the Nemesis National EMS Information System, and what you might be able to do with them. We'll then talk about some of the challenges and opportunities and review some EMS performance measures. As you probably all know, and we've done a lot of work on this for the past 20 some odd years of the Flex program, is EMS remains a challenging area of activity for states, and one that I think is getting increasing attention. There's been a heavy focus on training, meetings, and committee participation. Not that that's necessarily any of those are bad things, but that doesn't always connect to longer term outcomes. There's a focus on process and output measures, the things we can count, how many people come to a meeting, how much technical assistance has been provided, that sort of thing, rather than outcome measures. Some relatively unclear theories of change. How your project, by that I mean how your project is designed to make a difference and to go from the beginning implementation to the long-term outcomes. What we see so often is that grantees will start with the sort of process measures and output measures, look at the big changes that they hope to generate, but forget how to measure it in the interim, the short and immediate term. And I think that's really an area that's worth looking at. So let's start with the state data sources. This came out of work that we had done a few years ago. And it's always shocking. And I think 2 times that we've convened and recruited expert work groups for EMS, they've always told us the same things, that we don't really have a handle on rural EMS capacity, service areas, whether or not they can bill. We know they rely on volunteers, but we don't know how much of that, and we can't quantify that reliance. And this has been 6 or 7 years now that we've heard this same discussion. And so we began thinking about, as we pull this group together, is what's in the state licensure systems or run data that might be useful. So the first would be the state licensure. So we look at service licensure or agency licensure. So the agency itself, and personnel, which is the individual folks that are working in EMS, the state patient care or run data, generally done with an electronic record. And what we're seeing is that there's a fair amount there, but it's not consistently collected across the states. What we're also noticing is that state EMS bureaus are increasingly using their data portals to collect EMS data, to the point where sometimes it's hard to even find the individual licensure applications. It's all done through a portal. And there's some opportunities there, I think, that are helpful. And our primary piece of advice is to work with your state EMS bureaus to explore what's available and how to access it. We know from work that we're doing with some of the supplemental grantees, the EMS funding supplement, that they have direct connections because they're working with folks with that EMS experience to use data sources to and the state run data directly. There are other states that are having trouble, and it's been a barrier to getting to monitoring what they do because they don't have access to it. So I think, to me, this is something that's worth exploring. And probably before some of your projects get off the ground. So if we look at some basic licensure elements, we did a very cursory overview of state licensure applications for one of our last briefs. And it's basic things that you would not be surprised at. And what it basically, I think, does is provide information to look at where EMS is located in rural communities, what's the size and scope and services offered. So contact information, ownership, medical director information, levels of service, lists of vehicles and aircraft, ownership, dispatch information, and communication capabilities. And I think why this is important and why what started us down this road is we were working with one of the state grantees that had done an excellent survey of EMS agencies in the state. They had a graduate student that they were working with who was getting a PhD in focusing for his dissertation on EMS issues, but they had the darndest time getting the contact information. How would they connect with agency owners? They didn't have either contact names or they didn't have email addresses. And it was a significant barrier to getting the survey up and running. So that really sort of triggered us to think about what might be there. There are other elements that vary somewhat by state, a little bit outside of the core. To what extent are they using electronic patient care records? What's their billing capacity? What are their service area definitions? Do they define service areas? Is it something we could use, or you could use in the states to look at where the gaps in EMS are, where there are holes and where there might be what's called an ambulance desert. Some have staffing rosters by type and employment status. By that, I mean whether or not they're volunteers or salaried or paid employees. Some have estimated run volume, charges for ambulance transport. So there's a lot there. And while they're not consistent across the states, I'd encourage you to think about talking to your EMS bureaus to find out what's there and whether or not you could access it. I'm not really sure why there would be limitations on that, but for most flex programs working in EMS, they already have solid relationships with their state EMS bureaus. So I would encourage you to start that conversation. We look at personnel. So there's a lot of, they collect a fair amount of individual level demographic information for EMS personnel, whether they're medical responders, technicians, advanced EMTs, paramedics as examples, contact information, certification, current status, and work history. Some of that you may not need, but as we look through this, some of the agency applications are, since it's all going through the same portal, but a different segment, different tool, that they are able to connect how many personnel are working for individual agencies and whether they're full-time, part-time, volunteer, and by type. And I think that's really useful information. And finally, I'm going to scoot over with this. The one challenge I'm having is, for some reason, I can't get the bar from across the top of my screen. That sort of cups off the top of my slides. So next is looking at patient care and run records. And this is, I think, a really important bit of information that may be a bit more difficult for some to access, but I think it's worth exploring. So it's really a record of pre-hospital care and inter-facility patient transport care, involving patient demographics, the response time, what services were provided, crew members involved, service provider response times, travel distances, initial impressions, what was the illness, mechanism of injury, patient status, assessment of the scene and patient, vital signs, symptoms, history, and then a physical examination of the type and location of trauma, injury, or pain. So depending on what your intervention is, this can be really very helpful. And for the most part, patient run reports are required by states. They not very many options, although we've all heard the stories that some of the smaller agencies may not always file these in a timely manner. And that for some types of events, say they're dispatched to a scene, they arrive in the scene, and the patient or the person calling decided to leave, drive themselves to the hospital. They may not always fill out that information, although I think you should go back and look at what the your state requires. But I think it's important to understand why they do that. And it's really the information about what goes on. It supports patient billing. It's a legal record of the ambulance call's context and circumstance. Data supports EMS quality and performance improvement and can be used for research and tracking. So very important. And again, maybe a little difficult to access because of patient confidentiality issues and the like, but I think it's worth sitting down with the Bureau and the state EMS data manager to really figure out what you can do with it. So as I did a little digging around, there was a survey, and I didn't unfortunately put in the link to it, but I can send it around later. So what are state agencies measuring and what is important to them? So among the most common things that are being measured and monitored by state EMS agencies would be total response time, scene time, collection rates, STEMI recognition, cardiac arrest, return of spontaneous circulation, intubation success rates, and some other commonly included statistics are overtime hours and costs, turnout of shoot time, stroke recognition, and injury rates from lifting and moving patients. But I'm going to move through some quickly, and I won't spend a lot of time. I just thought it would be useful to look at some of, based on the survey, what are the most common things being tracked by state EMS agencies. This was a survey, I think, of 300 EMS state and state EMS officials. So among the operational data, 80% are tracking scene time, response time, 76% are scene time, particularly for STEMI, CVA, cardiovascular accidents and trauma, shooter turnout time, call processing, dispatch time. So all of these are at least 50% of the states that are doing it. So it's worth looking at what your state might be talking about. And then as you move down through, it starts to drop total task time, unit hour utilization, at patient side time, dispatching, assignment accuracy, and others. So there's work going on. And I think if you can align some of what your state is collecting with your interventions in a way that makes sense, it's data that you might not have otherwise. Under the clinical measures, STEMI recognition. So it's not surprising that you'll see a lot of the big time critical diagnoses being monitored by the states. A lot of it is time-based and response time. So STEMI recognition, cardiac arrest, intubation success rates, stroke recognition, IV success rates, time to 12 lead, ECGs, medication errors, and STEMI to balloon time. And then as you go below that, the 50% mark, cardiac arrest, survival, discharge, page management, restraints, sepsis recognition, heart failure recognition. So a lot of it is either clinical or the extent to which EMS personnel are recognizing certain problems on scene. A handful of states, a smaller number, but at least some are collecting information on financial data, collection rates, which is, I think, important. Revenue per transport, cost per transport, and other. Workforce data, hours, overtime hours and costs, turnover rates, employee satisfaction, employee wellness, meal breaks, and other. And finally, safety data tracked by states, injury rates, lifting and moving patients, everything else, vehicle collision rates, patient safety, lost time due to injuries, crew fatigue, violence against the workforce, 12-hour sleep time on shifts, and other. And I think in particular, some of this safety data is very important during COVID because of the demands it's put on ambulance crews and the workforce issues that you're all experiencing. So as you look through this, I'd really suggest that you spend time reaching out to your data managers, beginning to think about how some of the things that are being collected by your states can be used and accessed. The next group is for Nemesis. So Nemesis, I'm sure many of you know about, but it's worth, I think, going over some of the issues because there is always, I think, a little bit of confusion. Nemesis, or the National EMS Information System, is really an attempt to standardize data collection across the states. It's not perfect. It's not being implemented consistently by all 50 states at a level that perhaps we would like to see, but it's moving in the right direction. So I believe we're currently on version 3.5. It's point something or other, which I didn't bother to look at, but this is the most recent version and it gets updated and modified as we go along. So it's an electronic EMS system that collects and uses state local data. It develops and moves from the local level data, which feeds to the state, which can use that information. And then it moves, then the states will submit a course set to the National EMS Data System. Now, this is information I think that may be really worthwhile because it can give you some benchmark information, comparison data. Not always easy to access and make sense of, but it's worth talking about. It's a universal standard. So it uses common computer language, and I could tell you what XML is, but I'm not clearly geeky enough to remember. It's some sort of a common computer language, but it's done in a way that vendors, the folks that are doing portals like ESO, can use to move data. And so it's basically a three-tiered system with local agencies can select the elements that best suits their needs to collect and track. And they can keep the national, and then they also have the national and state elements as part of their work. The states then can select elements that are important to their needs from what the local agencies are collecting and keeping what they want as part of the national elements, which they then submit to the federal level. It goes to the Nemesis Technical Assistance Center, and it populates the national data set. We have used it. For example, we being a group that I worked with on the FCHIP, the Frontier Community Health Integration Network program in Montana, North Dakota, and Nevada, at least the original version. And we were using it to track some performance measures for those hospitals that had selected the option or the waiver to run their hospital-owned ambulance system, a critical access hospital-owned ambulance system. And so we looked at measures related to scene time, departure time, use of administration of aspirin and other things. And we were able to collect from the local agencies of the hospitals that had their own services, compare them to the state level, and with the approval of state EMS agencies, get that state level as a benchmark and actually national measures, as well. So how it works is that each state that's participating has their own line, has 3 directory accounts with 3 levels of access to the Nemesis data. There's the EMS state data manager, medical director, and the state EMS director. Now, there's also an optional category for states with a more trauma-oriented, I believe trauma-oriented data program, but that's optional. But these are the folks that have access to the data. And what I'd suggest is taking a look at your state's EMS website to see if they have procedures for acquiring access to state level data and how you would do that. If it's not available on the website, go directly to your EMS office, contact the state EMS data manager and explain the purposes of what you need. And finally, state contact information on state EMS data managers can be found on the Nemesis website. I don't know that it's always completely up to date, but it's a starting point. But I think it's really helpful to think about what you might be able to do with this, not only things that would be worth tracking based on your interventions, but also as a source of benchmarking and comparison data. Won't spend a lot of time on this, but there are basically 3 data dictionaries on the Nemesis websites. I've provided the links, the EMS demographic and state data dictionary, the national elements only, and extended data definitions. Just take a look and see what might suit your needs. So finally, I'm going to spend a little bit of time monitoring the impact of state EMS activities. This is something where we've done a fair amount of work. So some of the sort of past expectations, past areas of activity in state flex program EMS activity has been focusing on improving EMS engagement with CAHs, implementing a system of care orientation, assessing local EMS capacity and system issues, concentrating on the TCDs, STEMI, stroke, trauma, and we always use those 3 forever, but we've added cardiovascular accidents. So we developed some measures based on the work with the expert panel that focused on 3 domains of EMS activity: the capability, capacity, and access, recognition and diagnosis, and the integration and coordination of care. And a lot of this was driven by the expectation of the guidance and the program performance from state EMS for the FLEX program. So domain 1 was from NQF, but we also use this from the National EMS Advisory Committee that supports NHTSA. So system assessment really focused on things around capacity and performance using standardized tools and protocols. developing interventions that that address priority needs, beginning to implement interventions and focusing leadership on capacity building. And this from our expert panel was considered the most useful area of activity because it's something that we knew the least about. So in doing this, we looked at some of the capacity issues around agency data and reporting capacity. Can agencies collect and use data to manage and improve performance and engage in collaborative discussions? Are they using, the other was EMS agency and protocol use. Were they using nationally recognized protocols for TCDs and emergency dispatch for patients of all ages? And so we look at some of the others. Recognition and diagnosis was an NQF domain 2, the National Quality Forum, were they training staff to use evidence-based protocols for TCDs to identify specific episodes of care? NQF 5, domain 5 is coordination of care. Are they working, local agency working with other participants in local systems of care to plan for and develop integrated service systems? Now, a lot of this work came out of the early focus on TCDs where obviously with say STEMI, it's very much a time responsive need. And so for example, the door to balloon measure of 90 minutes, how well so the TCD systems often encouraged EMS agencies, the hospitals, other participants in the system to get together after an event and sort of break down what happened, what was a barrier to achieving the 90-minute door to balloon time, what facilitated it, and how could they make changes. So I think that's where that focus came from. And to be quite honest, not necessarily for every transport, but this is not a bad idea for ambulance systems to work with their CHs and other providers to begin to look at what's going on that inhibits the performance, efficient performance of local systems. So here are some of the measures that we worked with. Some of it comes from the program guidance and the program structure. Percentage of state flex programs that are conducting the assessments, number of state flex program initiatives that address priority needs identified in the assessments, those states that are tracking and evaluating progress towards priority needs, and the number of rural health systems involved with local system and assessment planning processes involving community providers and stakeholders. That is, are they working with hospitals, their local critical access hospitals, other providers, other service systems to sort of plan and develop the local system. Data reporting capacities. How many of your agencies are able to bill third-party payers and patients for services rendered? How many or what percentage of agencies can access patient billing and financial data for performance improvement? How many have formal quality improvement protocols and processes in place? How many are actually using quality data for performance improvement? And how many local regional systems of care are participants, in which participants are meeting regularly to review data? So again, these are all different measures that our panel endorsed and are out there. TCD, I won't spend too much time because I want to leave some room for questions, but are they using the CDC's guidelines for field triage of injured patients of all ages? Are they using the American Heart Association's Mission Lifeline guidelines for STEMI? Do they have protocols that meet current American Stroke Association, American Heart Association guidelines for stroke care? What percentage of units have formal emergency dispatch protocols? Working down through, we're looking at recognition of TCD, and these are some of the training measures we looked at. What percentage of staff are trained on STEMI recognition, stroke, or trauma and field triage? And as you think back to what some of the states are collecting and some of the common measures that they're collecting, these are not unimportant. protocol use, which ones are using certain guidelines, and a percentage, how many of your staff or EMS agency staff are trained on STEMI and stroke recognition, or training for trauma and field triage protocol. So again, I think some fairly basic measures. Coordination of care. I think this is one to me that I think the system of care orientation is very important, not only in EMS, but in regional and local systems of care anyway. So are your EMS agencies, how many of them have local planning committees? Are they involved with law enforcement, healthcare providers, critical access hospitals, community stakeholders to plan for their system and how it works? What percentage have local committees that have developed plans to address emergency system resource, workforce, and training needs? I think that it's very important to look at this issue, particularly in light of COVID and some of the emergency situations that have taken place between flooding, storms, and the like. How well are they engaged with as a community to operate efficiently and not each in their own silo? Then finally, some long-term improvement measures are what percentage have functioning as integrated systems of care. What percentage of agencies have improved performance on key TCD measures, and what percentage have improved financial and quality performance. So if you think about some of these issues, I think it's also important to begin to look at where the measures and what measures you might want beyond this. There's been a fair amount of work over time, and certainly there are some people on this call that are specifically working on identifying and testing rural relevant EMS performance measures. Florida and North Dakota in particular have supplemental funding projects at the moment where they're working in this area. But let's just go over quickly some other work that's been done in this area. EMS compass measures. This is a project funded by NHTSA and led by the National Association of State EMS Officials. And they pull together a wide range of stakeholders to develop and identify performance measures relevant to EMS agencies, regulators, and patients. Now, these measures are all based on the latest version of Nemesis. So if your EMS agencies are submitting this to the state and the state's collecting and moving it up to Nemesis, this is an opportunity to not only get state data on these issues, but also as a benchmark in comparison, but also perhaps national measures. Really focused on allowing local and state systems to use their own data meaningfully. And this work has been transitioned to the National EMS Quality Alliance, known as NEMSQA. And they're the group that is working very closely with Florida at this time to sort of test and validate the measures that they're working with. So I think it's really exciting work that they're doing. But I'll give you sort of a basic coverage of the measures that Compass looked at. So they were looking at measures related to managing hyperglycemia, medication errors, pediatric respiratory issues, seizure, stroke, trauma pain, and vehicle operations. So I I don't know why I did that. It looks like I have two copies of the same slide, so I apologize. But the second slide has the link to the website where the compass measures are located in a spreadsheet. So it's very helpful. If you want to take a look at those, please feel free. And then finally, as I mentioned earlier, the EMS agencies, 2 of the 8 supplemental grantees are specifically focused on identifying rural relevant measures. So Florida, currently working with NEMSQA, has what they call their FAIR project, which is feasible, actionable, impactful, and relevant measure of performance. Their goal is to identify rural relevant measures, and they're going to work with the National Quality Forum to get them validated and approved. I think it's exciting work. The same is true with North Dakota's measures development process. They're doing it a little bit differently. They are using a quality improvement program steering committee, and I believe up to 30 external subject matter experts. But again, here's a couple of areas. Both programs are really focused on trying to come up with measures that are not only useful for their state, but that can be shared with other states and provide some consistent measures. And the goal really is to drive measures that are not unique to their states, but more comparable across EMS, rural EMS in the United States, and to be able to pull them from the Nemesis using Nemesis elements that are focused on key performance metrics. So again, here's what I suggest. Really get involved with your EMS bureau and data manager. Understand what's collected and available through licensure, personnel licensure, and run reports. Be clear about what it is you need and how you might use it. But also figure out then what the access information is. You know, the access is needed. In some cases, if you're trying to get the information from outside of the state, it's often through FOIA, Freedom of Information Act request. But it's worth, as you look at EMS activities in the future, or perhaps some of you may be submitting additional applications, I should say, for the additional 2 years of supplemental funding that is available now. Here's an opportunity to get a really focused set of measures and potential data that can use not only as baseline, but to monitor change over time. I would encourage you, as you talk to them in advance about what you're trying to do. Oftentimes, I think most state EMS agencies are already engaged with the flex programs working towards the supplemental funding. But really think about what it is you're trying to accomplish and how, and what are the intermediate, short-term and intermediate and long-term measures that you want. And I think where we've seen some challenges, and it's been particularly, I think, with some states, and not just within the supplemental grantees that are working around community paramedicine. You know, there's the measures that are done by the community paramedicine, the Mobile Health Improvement and Performance Project. I always get the name wrong. I apologize. They really look at high-level measures. So we want to know if this small program in community paramedicine is able to reduce unnecessary admissions to the or readmissions to the hospital, or EMS unnecessary ED and emergency department utilization. These are great measures. They have a very substantive set of measures, but their data, the data that they're recommending is a bit problematic, because they're talking about using run reports and others, and the work that we've done in this area suggests some of the long-term issues related to reducing hospital admissions and readmissions and ED use requires access to a higher level of data, so that you can begin to really determine what the level of attribution is appropriate. So, but instead, I think it's useful then to look at community paramedicine, how things are changing, what the community paramedics are doing with patients in a way that lets you sort of say, all right, we're connecting them to family physicians. We're doing medication reconciliations. We have done a survey of their homes so that we can minimize fall risks. Or do they, one issue that we've heard about quite a bit is whether or not patients who are diabetic have appropriate refrigerators that can keep their insulin at the proper temperatures. Surprisingly, not all do. So there's a lot that they can do. And if you can measure those sort of things and sort of track them on an evidence basis, it lets you know that you're moving in the right direction. So that's really it. I'm open for questions and discussion if anyone has anything to ask.
It's Nicole. I have one thing I was hoping you could talk a little bit more about. as the Flex programs are thinking about that funding application for the new 2-year supplement that you mentioned, can you just talk a little bit about, succinctly kind of frame up baseline data, the need for baseline data, establishing it now, and also a little bit about outputs versus outcomes?
Sure. Well, I think at some point, if you're developing an application for the supplemental funding, you really have to have some basis by which you think particular intervention is important. So some of the programs, and I think have really, so Donnie, if I can use New Mexico as an example, has a program that's really looking at working with local rural agencies to improve their ability to collect, report, submit, and use data for performance improvement. Because of Donnie's involvement and what they're doing, they have been able to use some of the registration and reporting information as a benchmark and a baseline for what they're doing. How many agencies that are in the target population are reporting on a consistent basis? What types of are they reporting consistently and accurately? What are the problems? What are the issues that are going on? And that has been, I think, for them, a tremendous opportunity to be able to say, all right, we know what was going on. And if we're targeting 20 or 30 or 40 rural agencies, here are the problems. This is where we're starting from. This is why we think it's important to train them and to work with them and give them feedback on their reporting and how often they're using it. So they have both the data submission piece, and they're also working with medical directors to make sure the medical directors understand how to log into the system. New Mexico EMS, they call it Nemesis, New Mexico MSTARS. And so that, I think, is really important. So if you're deciding on an intervention, can you work with your state agency and others to collect some baseline information that tells you this is the right project? So if you start from beginning, collect it then you've got a starting point. And the other thing I would say is data is always messy and tricky. Don't let perfection be enemy of the good. Can you get the basic information you need from there? And so then that to me would be really important. So as you're now looking at these applications, find out what your states have, what you might be able to use as benchmark information instead of waiting till you're 6 months, a year to a year and a half into the program to think, how can we compare? How do we know we're making a difference? And so start with baseline data from the beginning, understanding what you can collect, how you can collect it, and at least getting approval from state EMS agencies to be able to work with the data upfront and access it and in what form. So that, to me, I think is a critical piece. And then as you work through your projects, what are the long-term goals? And then what are the short-term steps? Because remember, this is a 2-year funding cycle. It's awfully hard to have long-term goals. And if you're looking at something that you want to see big system change, like reduced EMS costs, reduced hospital costs related to unnecessary admissions or readmissions or ED use, reductions in the use of air ambulance services. That might be hard to see that change with smaller projects in the course of 2 years, but what are the steps in between that you might be able to look at? So if it's community paramedicine, what are your community paramedicine medics doing with patients that would lead you to believe it would help them reduce unnecessary readmissions, for example? And then what source of data is there? You know, if you're looking at using data from one hospital or two or local community, that's great. It'll give you some sense of what's happening at the local level. But what happens if a patient goes 20 miles away to another hospital or 30 miles away or has services elsewhere. So how do you know that you're capturing all the information? How do you know that some readmissions, some admissions may be completely necessary and unrelated to why they're being treated in community paramedicine? So those are all, I think, really important, is to break down those steps and work through it, and then focus on the evidence base. I know I sound a little academic sometimes when I talk about this, but I think the theory of change and really clearly thinking through how your project is going to generate the changes you hope to see is very, very important. I know some on the call may not be as fond of logic models as I and others may be, but they're an important tool. Now, the other piece of advice I would give is keep your measures reasonable and manageable. We all want to collect everything under the sun. I've learned this one from working with folks around quality improvement. John Barnes from Michigan sort of informed me on this one many years back, saying, it's not capture a few measures that you can capture often, track consistently, and feed the information that you need. Don't try to measure everything under the sun, because you can get lost. So keep the number of measures manageable, track from the baseline, look at short-term and intermediate-term measures more heavily, and then connect them to long-term outcomes based on your theory of change.
Thanks, John. One thing he said kind of early on in his response was about knowing the data that is available to you. So considering, we're using the FY22 EMS supplement as an example. It is only a 2-year project. And so using that first year as a planning, identifying who you're going to work with, gathering the data, what's available to us, that is, if you use your first year for that, you're taking up half of your project time and just kind of getting set up. So I guess I'd really like to strongly recommend that stuff you're thinking about now, and try to have as much of that in place as you get started, so that you're not set back by spending a lot of time doing that. As John said, it can be a significant setback to think you're going to have access to this data and then find out that you don't. And if that data is integral to your project, then you're going to spend a bunch of time trying to figure out how to get data that you need, surveying, gathering, trying to get that. So that was one of the key points I really wanted to make. And that isn't just for your FY22 supplements, but really all of your flex projects. Just really think about, if you are going to have access to the data you think you're going to have access to, have some conversations and confirm that, and you can save yourself some pain and heartache with that.
The other resource, I don't have a link to it right off the top of my, that I can post in the chat box, but I can send around also, is we also did a toolkit some time ago on logic modeling and outcome management. I think the important piece of that document is really the theory of change and the different steps and levels of outcome measurement. It would be useful to think about it that way. So, I realize that the data collection and all of this is tricky and it's difficult. But, I was thinking about this the other day, that we're now bordering on almost 25 years of the Flex program. Going back to, it was passed in the 1997, BBA 97. And so I think that focusing on outcome measures, and as we move forward, how can we really prove that 25 years of funding is important? And I think that is going to be, to me anyway, one of the bigger changes as we move, one of the bigger responsibilities, if you will, of state flex programs, the federal office, those of us from who are flex program partners, from Arquita the task of the National Rural Health Resource Center and the Flex Monitoring team really have some responsibilities to think about that as we move forward, because I scratch my head sometimes and wonder where 20 some odd, 25 years have gone. Because I must have been about 12 when I first got involved with the Flex program, I'm convinced.
Absolutely. Me too.
Exactly.
Okay. I think that's it. Not hearing any questions. I think I have a link to the logic model toolkit that John was talking about. I believe it's that, if you want to take
Yes,
a
it
peek
is.
at it.
Yeah.
Caleb mentioned in the chat that he loves logic models. So I would say if you have logic model questions, Caleb Syme at Task is your man. You can reach him, Syme@ruralcenter.org. He would love to answer your logic model questions. I'd love to answer your EMS questions or any others that you have. So you know where to find us, task@ruralcenter.org. Thank you, everybody, for joining this webinar. And
I should say, Nicole, that you're also, folks are also free to reach out to us at the Flex Monitoring team, me or Karen Pearson or others. And if you have data questions, we might be able to help with it also.
Okay. When we send out the recording, we'll send out the right link to the logic model toolkit, because that one seems to not work. So sorry about that, guys.
It's Karen just added it. So
Karen saves the day. Thank you, Karen. All right. Thanks,
well, great.
everybody.
Thanks, everyone.
Yep. Have a good day.